Hi, this is Bob Burns with the National Center for Health and Public Housing. I want to welcome you all to the Health and Public Housing Advisory Group. And if we could just do a quick, roll call of who's on the phone. Zara, are you with us? Alan Citron? Joe Fuentes?
Here.
All right, thanks, Joe.
Sure.
Okay. Henry Taylor? Alan Patterson? Allison Dubois?
I'm here.
Great, Allison. Glad you're with us. All right, that's terrific. And, okay, Alan Cintron? Somebody's showing me something, Alan, that's showing me that you're on the phone. I'm wondering if you're...
He's muted.
Oh, you're muted. Okay. Well, Alan, when you get a chance, kind of unmute. Alan? Okay. Zara? All right. Okay, any other folks on the call right now who would just like to introduce themselves?
Hi, this is Nancy from Caroline's Health Center in Cleveland.
Oh, great. Yes, thank you very much for joining us.
Good morning.
Go ahead.
Good morning. This is Henry Taylor from Miles Square in Chicago.
Oh, Henry, great. We're glad you made it.
Thank you.
All right.
Hi, this is Kimberly Spruce from Primary Care Health Services in Pittsburgh.
Oh, thank you. Thank you, Kimberly. Glad you made it. And pass our regards on to Len.
I will.
Thank you very much. Okay, anybody else? Okay, I guess that's it. All right. I hope most of you can see the slides just to help us stay a little bit organized in the discussion. But if you take a look at what's there, basically we're going to just do a quick review of a number of areas. We don't have a lot of time for the call. We do have some housekeeping discussion to do in a minute regarding future calls and the amount of time and future get-togethers and all that kind of good stuff, so we'll do that in a minute. But we want to run through today, of course, the advisory group, and then want to tell you a little bit about what NCAs, National Cooperative Agreements, are doing relative to health centers and what we've been charged with through HRSA of late. And also we have some very specific topics of discussion listed below on quality of care and mental health and smoke-free public housing and diabetes and cervical cancer and substance abuse. And towards the end, we're going to talk a little bit about emergency preparedness. And I'm just going to mention that probably the greatest reason that's back on the agenda and I guess in the sights of HRSA again are all the storms we had over the past year. And I know we've got Joe and Alan, Joe from Houston and Alan from Puerto Rico on the line who lived through them. So that's going to be another hot issue again this year. Moving on to the next slide, we're looking at some of the advisory group itself. And we've kind of talked about this before. We're looking for folks who can kind of provide their insights and their concerns and their interest, and can be there for meetings and to give us input on different issues or make suggestions about training and technical assistance and outreach and all that good stuff. And within that, we've got some specific items that we want to just tackle up front. And I guess the most, this is a very basic thing. But first of all, we're talking about doing a quarterly conference call, and I guess I'd like to get a little feedback from folks as to whether or not quarterly is sufficient. I know for everybody, time is at a premium, and so it's very difficult to try to find a time and a place to get everybody together. So one thought someone suggested was perhaps to maybe go with more frequent calls, maybe every other month, with the notion that some folks, just won't be able to make it. Or we stick with the quarterly and perhaps elongate the call. Maybe we go to more like an hour and a half. So I would like to get a little feedback from you guys on that. And so, if you want to start, I don't know, Allison, if you want to express, your opinion, go ahead, and we'll kind of go on from there.
I have to be honest, I'm not sure that more than quarterly is feasible for me. So, and I really wouldn't encourage us to entertain, well, sometimes you can't make it. So, I think that's hard. So my recommendation is quarterly.
Okay. Anybody else?
This is Joe. I think quarterly is fine unless we find out that we need more time, maybe extending it if we need to, just, with advance notice, of course. But I think quarterly for right now is fine. Okay. Anybody else? Zara or go ahead.
This is Veronica. Good morning, everyone. I think quarterly is fine, knowing that we all have time constraints.
Okay, great. Okay. So, all right. So is there anybody who feels that quarterly is not sufficient? Okay, so we'll go with that. And then what about the notion of going to a slightly longer time frame on occasion, going to perhaps an hour and a half?
This is Joe. I think on occasion is the right word.
Okay.
But again, we would know that hopefully gives us 3 months to plan, I guess, for that extra 30 minutes. So I'm fine with that.
Okay. Anybody else? Kimberly?
I agree. Quarterly's best.
Okay. All right. That sounds good. All right. If we can, we're going to just move down to face-to-face meetings. And this is kind of a significant issue. It has become more difficult, I guess, to find the right time and the right place to do a face-to-face conference. And want to get some input on that. Our last conference was around this time last year in Chicago. We did a regional. We thought it was good. We got good reviews on it from folks. We would have liked to had some better attendance, but I know everybody cannot always make everything. And what was unique about the conference this year, I guess, was we had some great partnership help from Henry Taylor and the folks at Miles Square, and that the second day of the conference was actually done at their location. So we combined kind of a site visit to their facility and a tour with going over some very interesting discussion, particularly around precision medicine. And so there's a lot of things we could do. We could go with try to do a national every other year, and do a regional, on 1 year. We could also try to integrate, use less hotels and more, partner space, if you will, in that, as you probably well know, HRSA no longer really funds conferences, so it's always a tricky thing to make sure that they kind of we at least cover costs with them. So in terms of, a national or a regional or the timing of any of those things, any feedback from anybody? Henry, any thoughts?
One of the thoughts I wondered, Bob, was the opportunity for tacking on to an existing conference, adding a day, so that you get economy of scale. Have we given thought to that?
Yeah, and we have, and we've kind of had some informal discussions with some of the other NCAs along those lines, and it's just a matter of when and where, and I think there's some concern because people like to feel unique, and so they don't necessarily want to have their identity or their priorities subsumed to somebody else's. In that kind of arrangement, so it's not been as easy as you would hope it might be. And then, of course, there's always trying to piggyback on NAC events, but NAC events are so long as they are. Whether it's CHI or PNI, that I don't know if people could do it. So if we tacked on a day or a day and a half, could people be someplace for a week? I mean, because I know, like Henry, I know you're in a lot of the committees at NAC, and when you go to NAC, I mean, it's a, you know, you're there the weekend and you might be there through Wednesday, so it's a significant amount of time.
Right.
So I don't know if that works for folks. Veronica, any thoughts?
I thought the same thing as Henry. I seriously thought about that because I think for some of us that would be easier. We're there anyway.
Yeah.
And it doesn't have to be like an additional 2 days or whatever. It could be a good, robust half a day or 1 day.
Okay, that's an interesting idea. Okay, just to kind of cut it down a little bit and be all right. Okay.
Yeah, because most of us are there anyway.
Okay.
And our staff who attend, they don't have to be there the entire time. They could come in just for that 1 day or 2 days.
Okay. Well, are there specific, so would it be possible, do you think? I mean, because obviously NAC is probably has the events that most people attend. So is it practical to add on a day to a NAC event for you guys?
That would be a
So
preference.
I'm fine with that.
And doing it early, so starting early,
Yeah.
I think is better than trying to tack it on the end.
Okay, because people are burnt out.
Agreed.
Okay. All right, that's very helpful, because that certainly allows us, and it gives everybody a lot of time to plan and schedule and all the rest. So if the people, anybody who does not like that idea, okay, all right. Well, why don't we go ahead and explore that then? Why don't we'll go ahead and we'll take a look. I mean, obviously, if we wanted to try to do something for, you know, to give people sufficient notice, I guess we've got really 3 events, and there are really 3 events we can deal with. We've got, you know, the March P&I session. We've got the August CHI session. And we've also got the PCA HCCN meeting, which occurs, you know, in November. Now, I think the first 2 events are certainly more well attended. What do you guys think about, given the amount of time? You know, it'd probably be better notice if we did something in August. Does that seem like a reality for folks?
August seems like a good time frame from my perspective. Bob, that works for me.
Okay. Any other feedback on that?
I think that that's the most helpful as well, because the
Okay.
CHI has a focus on program, and it just, I think it marries better with the work and the attention we would have to a public housing focus.
Okay, and I mean, I don't know offhand. I assume CHI is in San Diego again, but I don't know.
I can check. It rotates, Bob.
Yep. Okay.
Yeah.
Okay.
I can certainly check.
But we can, yeah. They might even have that up on the site already. They probably do, because they
should.
They do multi-year
Yeah,
agreements, so they're in pretty good shape. Okay, that sounds.
Usually not back-to-back years in the same city. It usually alternates.
Okay.
So, and I'm not sure if it's back in Chicago next year.
Okay.
I'm fine.
Well, people love Chicago. I will tell you, a lot of folks who came last year, you know, asked if we could have it in Chicago every year. So that's a testament to the city, and I guess to the good folks at Miles Square who were so helpful last year.
Well, thank you.
All right. Let's see, and then
It's going to be in Orlando.
okay, okay, it's going to be in Orlando next year.
Okay.
Okay, so the 24th to the 28th. So we would try to do something, say, on the 23rd. All right, so we'll go ahead and see what we can do with that, and we'll get you know, some notice out to folks after we've done a little research. But if that sounds good to people, then I'm sure it'll sound good to the rest of the grantees. So we're going to go ahead and pursue that. Okay. And as far as the other issues, feedback and all that kind of thing, one thing we just discussed, the last few days, and just wanted to get your feedback. If we were able to put up some, and I'm going to just call it a bulletin board, but basically, kind of some kind of place where people can put out issues or concerns or information, and we can kind of communicate informally, either some kind of Google group or that kind of thing. Would that be something that would work for people, or do people have a preference for some other mechanism? Try that again.
I don't have a preference.
Okay, but is it sound like something worth pursuing?
Yes, I think it's helpful to have a place and to pose questions and to share and for folks to have a vehicle.
Okay, that sounds good. So we will go ahead and kind of put something together, and we'll get out to you.
Sí. Yo lo que bajé fue esto, lo de la agenda, pero no veo nada.
Pero ahí se veía la agenda dentro de
Oh, that's out.
Yeah.
Puede ver que está bien lento el internet.
Oh, okay. Apparently, Alan didn't know that he wasn't muted. Okay. All right. We're gonna kind of move off the advisory group discussion for now, if that's okay. Does anybody have anything they want to add relative to the advisory group itself? Anybody? Okay, we're going to move off the advisory group then for just a second, and we're going to just jump into the NCA goals. And these goals basically come largely from HRSA, and a lot of them are kind of the traditional goals, really, increasing access to care and quality care. There's a big focus, as you know, on getting hemoglobin A1C, under control, and uncontrolled diabetes under control, and promoting health equity. In terms of the development areas, workforce is preeminent, health professional training, team-based practice models, increasing capital development and medical legal partnerships, promoting IT system transformation, and also health. So those are some traditional goals going on. The right side of that slide you see talk about the National Resource Center, and I'm going to come back to that later on. And right now we're going to go back to kind of some discussion topics, and probably the lead priority for HHS right now is diabetes. And I'm going to turn it now to Dr. Jose Leon, who's going to kind of run you through what's going on there. So go ahead.
Thank you, Bob. Good afternoon, everybody, and good morning if you're on the West Coast. As Bob mentioned, this slide shows the special and vulnerable populations goals, and the advice that we have received from HRSA is to work on 3 areas. One is increasing access to care for underserved populations, improve health outcomes, and that one is in particular the main push that everybody is doing, not only the National Center for Health in Public Housing, but the other 19 NCAs and PCAs, ACCNs are working on this particular clinical performance measure to try to reduce the number of patients with uncontrolled diabetes. The number at this moment, if I'm not mistaken, 2016 data shows that 8% of patients being serviced by community health centers are diabetic, and around 29% of them have uncontrolled diabetes. So it's a little bit higher than the 2020 goals, which is around 18%. That's the national number. So the idea that we have for the next 3 years is to try to reduce the number at least 5%. That is the goal that is being set by HRSA and specifically VPEC. So everybody is working on all this stuff. And the last one is promote health equity. That's the third goal. So in order to address the three areas that I just mentioned, these are the future topics for discussion that we have included in our work plan. We are going to focus a lot on diabetes and social determinants of health, cervical cancer, access and quality of care for the aging population, the disabled, and the mentally ill. Substance abuse is another priority for HRSA, as is childhood obesity. And we have also included telemedicine, a medical legal partnership, and HIV/AIDS as the future topics for discussion. So if you have any other ideas, if there is any topic that you believe is an emerging topic that we should include, you can let us know. We can include the topic and discuss it. At this moment, in addition to the advisory group, we have also established a clinical quality group. We have some members of your health center participating in these calls. We have had a call on diabetes. We have some calls on cervical cancer, and we are working with your medical staff. If there is someone right now on this call who would like to include any of the clinical staff members and participate in this call, they are more than welcome. Just let me know. Send me an email, and I'm going to send that information to everybody. So these are the main topics, and just I would like just to briefly mention what the goals are, and this is coming from HRSA. Basically, HRSA is making this big push, and there are some prevention efforts and some treatment and management efforts. The three clinical performance measures that we are trying to improve are first increase the percentage of adults who receive weight screening and counseling, and the percentage of children who receive weight screening and counseling. And for the treatment and management is the A1C value. That's the main performance measure that we are going to work on. I can mention that here at the National Center for Health in Public Housing, we've been working with the American Diabetes Association. We've been getting some feedback from them, and they are going to participate in one of the webinars that we are planning to host in the month of February, and they are going to talk about the new standards of care that they are going to release in the month of December. And this slide just shows that this is a joint effort. It's not only NCAs, but ACCNs, PCAs, NAC are working together and trying to improve the diabetes numbers. In regards to the activities, there are some activities that are conducted by the NCAs, but there are other activities that we are working with a diabetes task force. This is a group of national cooperative agreements. And there is another one from NAC. We are part of the committee. We are going to provide some recommendations for health centers. We are in the process of reviewing all the information, all the standards of care from AD8, and reviewing all the data, the 2016 data, and you are going to get additional information from us as this collaboration evolves. And I turn it back to you, Bob.
Okay. As you know, and I'm sure, as you folks have attended, some of the various NAC events or had any interaction with HRSA, the learning health system is really a major focus, and it's a major focus for us as part of that effort. We've had a lot of, I guess, yes you can and yes you better discussions with HRSA, with Jim McCrae, with Sumanir, about adopting the Learning Health System, and I think that they're really kind of going for it in terms of integrating, all the possibilities that are out there now with data analytics and artificial intelligence, and building, and then partnering that with patient and clinician relationships, trying to develop incentives, leadership culture, the whole thing. And as part of this overall effort, I mean, really, we're kind of in the middle of. I'm just going to click the slide here. Sorry. Communications, collaboration, and coordination. Right now, we are in all the national cooperative agreements really caught up in an incredible amount of collaborative activity, and I'm sure the health centers are going through the same experience. We are spending more time talking with partners, trying to coordinate with partners than we ever have before in a whole host of areas. It's around trying to really further this Learning Health Center system. And as part of that, if you can now, we're kind of caught up in what's called the National Resource Center. And I guess I'm going to take a step back here and kind of just, I guess, give it context. And I'm going to say some things that are probably profoundly obvious to most of the folks on the phone. But the reality is that everybody here doesn't have enough time. Everybody here is inundated with communications, with data, with information. It's like drinking from a fire hose at this point. And at the same time, we all have incredible needs for real, useful, knowledgeable, just-in-time information and a way to organize and utilize that information to improve health outcomes. And so, in part of that effort, I mean, as a beginning effort and as a way to more efficiently provide training and technical assistance, there are a couple of priorities that have been established with HRSA, and again, we've had some pretty lengthy meetings with the folks at HRSA, Jim McRae, Sue Manier, Tracy Orloff, to try to further this effort. And as part of it, and this is really, we really just started this back in August. We had the first real discussion at CHI. And then we had a follow-up session in September, a follow-up session in October, and we've kind of got some things going on. And the two, I guess, initial activities or primary activities are to establish a training and technical assistance clearinghouse, and to conduct one national training and technical assistance needs assessment that will be, administered to all the health centers. Currently, of the 20 national cooperative agreements, there are about 17 different needs assessments that go out to folks. And the goal is efficiency and trying to help all that. The clearinghouse, the notion is that there will be a single web portal that folks can go to, health centers can go to, and on that portal, they'll be able to access, or at least first identify, the appropriate resource within the group of NCAs, and also to identify the appropriate tool. Now, it might be I shouldn't use the word tool, but let's say a resource, and the resource might be a publication, or it might be a podcast, or it might be some kind of training module. It could be, any number of things. And so, in terms of activities, what we've done so far is we have all the national cooperative agreements have basically put together an inventory of, say, their 20 greatest hits. So their top 20 resources, those podcasts and assessments and abstracts and and fact sheets and all the rest. So we can see what's out there and people can access them. And then in addition to that, we can identify possible areas of collaboration and areas of duplication so that we can kind of improve ourselves in both those areas. The needs assessment right now, the effort is kind of going something like this. The first step has been to take a look at what people have existing for needs assessment, And the reality is a lot of the national cooperative groups have been using the needs assessment to gather a lot of information they didn't feel like could gather easily elsewhere. So we're looking at existing resources, looking at overlap in some of the different surveys and focus groups that focus on.
I hate to interrupt. I have a question. If and as this national needs assessment survey goes out,
yes.
One of the things I've continued to think about from a national perspective is it might also be really good to incorporate in that what are health centers doing? Because when, for example, we were exploring urgent care, there was no easy way to know what other community health centers were doing that work so that we could reach out to them. And, that happens over and over again in terms of practice acquisitions or building a specialty component or medication-assisted treatment. So I just wonder, in terms of how the work is happening and the collaboration across the central office grantees, is there some thought of incorporating not just what needs do we have, but what resources and or specialty and
yes.
or innovation are we already engaged in so that those linkages could be made?
Yes, and I think that's definitely under consideration because there's a whole group of folks who are working on this, and I think the idea is how can we get the information that we need and make it as painless as possible on the health centers themselves to get it together, and then how do we go ahead and use that information and act on it to for the good, whether it's better training and technical assistance or better collaboration or better training protocols or better understanding of best practices or whatever. But I think that's an excellent point, and that's something that Jose is for example on the working group for the needs assessment amongst the NCAs, and I think they're actually Friday.
We have a conference call, yes, tomorrow.
Mm-hmm. And actually, so we will actually pass that on for sure. So definitely. The timing on this is we're hoping to have by the spring kind of a prototype of what the single needs assessment will contain, so that we can get it out. And also by June 30, July 1, we would like to have probably at least some kind of inventory or a very rough clearinghouse portal up, so people can get benefit of it. But one thing I will tell you is, as part of this process, we've looked at some existing clearinghouses, and there was one that everybody likes that was done by Georgetown University for maternal and child health. And it took them 8 years to put it together. Now, I say this not to say it's going to take us 8 years to get this together, but to say that there's a lot that goes into it. And the great thing is that we will benefit from some of the lessons that they've learned and that other folks have learned. So the plan is that we will go out. There's going to NAC has been funded to get a contractor to work on the technology piece of this thing. And also to do kind of a formal environmental scan just to see what other tools are out there, and the same thing around the needs assessment. There's going to be some assistance in developing that single needs assessment and the best vehicle for doing it. And the needs assessment may be some combination of a survey and focus group and that kind of thing. And I'm telling you that because we are still in the building phase, and we have not even kind of, as a group, the National Resource Center, gone forward with reaching out to all the health centers, because we're really just at the planning stage and development stage, and we want to have something before this really goes online. So be patient with it, if you can, and understand that we'll probably be reaching out to folks at different times to get feedback. And anyway, but much appreciate you listening on that. And at this point, we're gonna kind of get away from that a little bit, and we're going to get into some specific topics that Jose and Saki are going to deal with, and I'm going to turn it to Jose.
Yeah, before we move on, does anybody have any questions on what we have just discussed? Lots of different. All right, so let's move. As we mentioned, and this is data that we have gathered throughout the years. This is from our last needs assessment, and one of the issues that we are going to address is the healthcare for the aging population. According to CDC, elderly patients living in underserved areas face multiple barriers to care, and these barriers include lack of transportation, insurance, or family support. There is other issues like poor patient healthcare provider communication, some health literacy issues. So that's one of the reasons why we are to explore what you are doing in regards to the services that you are providing to the elderly. Even though most of the health centers, and specifically those PHPCs and health centers located in or immediately accessible to public housing, provide services to the aging population, there are still some needs that are not covered. So I would like to ask if you can give us some update on what is limiting the access to care to the elderly population living in public housing. Anyone who can take that call, who can provide some feedback on the barriers or what is affecting the elderly population in the area where you are in?
Well, so this is Allison. So, we're in Peekskill, New York, is our one of our locations, and so I think one of the things that we continue to find is transportation barriers are a particular issue. Social isolation continues to be an issue that seniors in public housing are facing. Even in where we're able to facilitate connection, there's still trepidation around participation or spending time in some of those group settings, and so social isolation continues to be an issue there. And I think that, as you referenced earlier, significantly high rates of diabetes among our population.
Mm-hmm. Now, thank you, Alison. This is very helpful. Now, is there any program that you have in place to try to reduce these barriers?
Well, we can't quite address the transportation. Haven't figured out how to buy buses yet. But around social isolation, we did and continue to do a multi-generational program called HUGS, Health Unites Generations, which is an innovative model that links teens who are, so after-school program that links, kind of higher need teens to structured activities with seniors, and so we've done that for a number of years, and that helped both in terms of intergenerational exposure, but really developing some relationships between seniors and teens, and that's been a really a worthwhile program around the social isolation. The diabetes piece, I'm still looking for a magic bullet. We've done some work around, a Biggest Loser kind of concept where we had prizes and we're looking for folks to participate. We struggle with participation in group meetings in our health center and our public housing centers. Participation in ongoing groups is hard. We've been exploring some web-based resources, but again, for seniors in particular, that's challenging because as much as we like to think that we're bridging that digital divide, it still exists for our patients.
Okay, thank you so much. Now, I have a follow-up question. With all these issues that you mentioned, are there any quality measures that you have or you are monitoring in addition to diabetes for the elderly population?
I'm not sure that I could say anything we we run in quite that way. So certainly looking at diabetes and looking at, our organizational quality metrics by special population is something that we do, but they aren't particular measures for seniors within that setting. It's really more around the analysis between settings.
Sorry, and who is providing us the geriatric services? Do you have a special, do you have a staff?
We don't have a geriatrician. We have internal medicine clinicians. But we don't currently have a geriatrician on our team.
Okay. Now, probably this is the last question that I would like to ask you, Alice. I'm sorry. What is, we've been working with VA. We've been having conversations with them, specifically the services that are being provided by them. And I understand that some of the patients are veterans. Is there any collaboration that you have either with VA or any other agency, either a state or federal agency, to address the needs of the elderly?
I can't necessarily. I mean, we've been working with the VA. We just did a dental VA day for Veterans Day. But again, not particularly focused on seniors. So we've been trying to enhance the relationship with the VA, but really from a broader population perspective.
Great. Thank you so much. This is very helpful.
What percentage of the population is elderly?
But that's something that we can get from.
Sure. Okay. Yeah.
I'm sorry. Somebody else who can provide some feedback on this particular issue.
This is Joe. I mean, we do similar work in terms of just making sure that we have referrals and linkages to the VA. And since I used to work there in the past, that was the easiest part. But what I'm worried about more is just that we have the aging population that's coming. And so with our, the recent hurricane that we have and its impact on certain public housing properties, are we going to be able to absorb all that? So we're kind of in this flux of trying to figure it out in terms between public housing and then on the side for healthcare for the homeless in terms of making sure we have enough units of permanent supportive housing in the city, whether they're older adults or not. And so in terms of older adults, that seems to be fine with us right now because our specialized public housing residences for that. But I can see it's going to need to increase as our population ages.
Okay. Thank you, Joe. Thank you so much. Joe, is there any type of communication that you have with seniors? Sometimes it's hard to reach them, specifically when you have an emergency or an event like a hurricane. Do you have do you communicate with them with via portal or any other kind of type of communication that you have with them?
Sure. So it's done several ways through a portal. It's done through the EHR system if there are primary care patients. If not, most of them are likely getting case management through us. And so the case managers are deployed out there to make sure they're okay or through phone calls. So it's home visit, phone call, and telehealth, I guess, but not telehealth. What do you call it? EHR through the system, through text or even email.
Okay. Excellent. Thank you so much, Joe. Thank you.
Sure.
Somebody else? I may want to comment on this. All right. So there is another topic that is very important too. This is the mental health and the opioids and the opioid abuse, and this is as you know, this is an HHS priority. We've been working with SAMHSA. We've been working with Maryland Department of Public Health, specifically Baltimore County Department of Public Health, and other stakeholders. We recently participated at a conference in Baltimore. This was the NARSA conference. And this is a topic that we had the opportunity to discuss with not only the public housing agencies, but the public housing residents in particular. We had the opportunity to talk to them and show them how to use the opioid antidote, naloxone, and it was very well received. In fact, they asked us to do a webinar on this activity. And as you know, not only state agencies, but federal agencies and everybody is working on this particular issue. So the question that I have is, if you have any kind of program to address the opioid epidemic in that area, and if that is a big concern among public housing residents, at least the public housing residents that you serve.
This is Joe. We were funded under that last expansion grant to do MAT, and two issues that come up are just getting the number of providers. Right now, we had two. We originally had 2 providers that were doing, and that was adequate. However, one just moved, so we need to hire somebody else to get them trained. So that's been an issue. In terms of just the epidemic itself, we haven't experienced it as much as the North has. I'm from Houston, Texas, so we do see some of it. A lot of it, what we're doing in order to, when we find individuals, is using SBIRT a lot and getting that through that information, or through self-identified, or through self-reported, or through staff-identified observation. But a lot of it's becoming through the utilization of SBIRT, as well as clients actually divulging that information to us.
Great. Thank you, Joe. Joe, question: in addition to the opioid abuse and substance abuse, what other mental health conditions are prevalent that you are seeing, either anxiety, depression, or any other kind of mental health?
You named it: anxiety. You named it: anxiety, depression, PTSD, and some cognitive impairment. And so those have been the most ones that's come up. We do have a LGBT population as well, and so sometimes that has to do with some ego dystonic issues. But other than that, and some TGs, transgender, we have a lot of male to female transgenders, and just working through that process. And so, but in terms of just the biggest ones that we see from the general population has been depression, anxiety, PTSD, and some cognitive impairment issues.
Okay, thank you. Joe, now that you mentioned the LGBT population, we recently talked to another health center, and they are working with another NCA, Fenway Institute, and NAC. Is that part of the program that you just mentioned, or the activity that you just mentioned?
No, so we originally were founded as an AIDS service organization, so the prevalence in MSM and stuff has always been there for us, and so we were quite familiar with the healthcare needs for LGBT and QI, and I get confused about how many letters I need to add now, but in terms of that, we've always had those services in that population. So the answer is no, we haven't done that. But in terms of support services, we have Ryan White Part A, Part C, Part B, we have all that. We have housing. We just have different services, and so it's a little bit. And some of the staff is reflective of the LGBT community, and that makes it very helpful here. So nothing in terms of working with that project.
Okay, thank you, Joe.
Sure.
Somebody else who can provide some information or feedback?
Jose, we have a growing substance abuse program at Miles Square, and we're staffing it up. The challenge we've seen is finding adequate staff to provide the MET program. We're trying to train more of our physicians to participate, including our residents, to participate in the program. The need is outstripping our expectations, so we have a growing population in our community. We're getting patients from all across the city who, in fact, are looking for services. So we're just trying to meet the demand. We are doing a number of group visits in order to accommodate services. We're also trying to get our DASA license to provide that full service to this population as well. We provide a comprehensive array of just behavioral health, and we're seeing not only depression, anxiety issues in our practice, but we're also seeing some trauma-related issues with our children as well, as we have our adolescent programs and school-based programs underway.
Okay, this is really good. Thank you so much, Henry. In regards to the trauma-related issues, we've been working with SAMHSA, Is there any activity at the state level, Henry, that you are aware of in regards to trauma-related issues?
Yeah, the city had put out some activities towards trauma-informed care, and we're developing a trauma-informed model of care in our practice. So we look at our patients, especially our young adults, in that regard. So there has been some activities from the Chicago Department of Public Health, just in relationship to trauma-informed care and the model that they wish us to sort of follow in that regard. So we're educating ourselves and trying to implement accordingly.
Great, thank you, Henry. Thank you. Anybody else who has any comments or any feedback on this issue? All right, thank you so much. Now I'm gonna turn it over to Saki. Saki is our manager of research, policy and health promotion. She's been working on smoking cessation. She just recently presented at the American, at the APHA conference, and she's been working with HUD on the smoking cessation. So Saki.
Hi everybody. I know a lot of you have been working on smoking ban in the public housing agencies. I'd just like to start off the discussion by asking you where you are in terms of implementing the smoke-free rule. Has everyone collaborating with the public housing agencies to work on the smoking ban? And are any of you currently educating your residents, or are there any places where the smoking ban is already in effect?
Hey,
So I guess why don't I just ask the first question is, someone who is currently collaborating with their housing agency on the smoking ban, kind of talk about that collaboration effort.
We're not actually collaborating. I mean, I think that our efforts around the smoking, our work in smoking cessation has been ongoing. We did offer more. We did, sort of engage and put some more informational materials up, and we made sure that the, that our housing authority was certainly aware of the resources. But I'm not sure I'd call it, it wasn't a particularly new initiative. It was really just making sure that folks were aware of the resources we were offering.
I'm sorry, is this Allison?
Yes.
Yes, it was.
Thank you, Allison. Allison, just a quick question that you were mentioning this. We recently went to Atlanta, participated. There was a workshop that CDC put together, and one of the issues that we noticed, or that at least the feedback that we got from state health departments, is that state health departments sometimes are unaware of the health center activities. Specifically, we talked to the cancer control coordinators and the smoking cessation managers at the state level. Is there any collaboration at with the state health department, and specifically with the cancer control coordinators?
Yes, because there's a regional model in New York where there are agencies who've been really awarded and spearheaded that. So we have relationships with those individuals, and New York is in the middle of delivery system redesign. And so, one of the stakeholders that was brought together in those conversations were the agencies who were charged with looking at tobacco use, in our geographic regions. So I would say that while I'm not sure the state so much is aware because of the nature of it being the state, I do think that because of New York's methodology of identifying a local agency to be the lead, we have been connected to the New York State process.
Okay, thank you. Sorry, Saki, to interrupt. Go ahead.
No, that's okay. Allison, You mentioned that you, like your smoking cessation is kind of ongoing. I was just wondering if you're monitoring utilization rates for smoking cessation services, and if you've seen any uptake in it, or if you had to make any kind of staffing changes because of an additional need.
I'd love to say we did, but we did not. You know, and really, I think we did see some additional inquiries on the part of individuals with the clinician in terms of nicotine replacement therapy, which continues to be, you know, a strong part of our response. You know, I wouldn't say that folks were engaging in any of the other types of activities or supports in any of a significant way.
Do you all use community health workers, or who is it that provides the outreach for public?
We do have community outreach workers. We also have AmeriCorps members, and we have some other grant-funded staff who are deployed in public housing on particular initiatives. So, you know, and we have, so it's sort of varied.
Okay, great. Is there anyone else that would like to share what they're doing on smoking cessation? I see we're coming up close to the hour mark, so maybe I should turn it back to you, Jose.
All right. Thank you, Saki.
Yeah, thank you.
The comment that I have is whether, I mean, if there is any topic that you believe is important that we can include in these discussions, let us know. I believe that this is, your feedback is always very important. And what we are going to do is that all the feedback that we get, all the information is going to be in a publication. And before we send it to anybody else, we are going to share it with you. So in case you have any comments or you would like to add additional information, let us know. But I understand that at 2 o'clock there is a webcast, a BPEC webcast that I believe that most of you will be participating in. And that's what I have. I'm not sure, Bob, if you have anything else.
One just last question on smoking cessation, and that is there anybody who is using a certified peer specialist in terms of cessation counseling for smokers? Anyone?
Hi, this is Sarah Lang in Columbus, and it's not been consistent, but we have used peers within the public housing areas for smoking cessation, and it was a partnership not only with the public housing, but also with one of the largest churches actually supported the effort.
And were any of the counselors actually certified smoking cessation counselors or certified addiction counselors?
They were not certified. They were trained by one of the universities.
Oh, okay.
But not certified.
Okay. Was it the University of Florida or was it in South Carolina?
No, here in Columbus, Georgia.
In Georgia. Okay. Great.
Columbus, Fort Benning. So we utilized the college or the university here in Columbus for that training.
Okay, because we are exploring a program with CDC and a bunch of other folks, which we'll hopefully be able to tell you more about when we get together, and we'll issue some communications on it that's trying to be developed right now in this area. But anyway, thanks very much for attending the call. I know we're out of time. We're going to follow up with kind of some notes from this, and also we'll get you some more detail on some of the topics we've discussed. We would definitely like to hear back because you probably get something, especially Joe and Alan, relative to emergency preparedness, because we've been kind of pushing it for years and with kind of mixed results, because some people aren't particularly concerned with it until the latest disaster. But because of what occurred over the last few months, particularly in Houston and Puerto Rico, folks are very focused on it right now, and so there's some leverage there. So we may reach out to try to get some information and also to provide some information. So we'd very much like to hear, especially from Joe and Alan. And as for the rest of you folks, thanks very much for making the time. We will explore kind of some of the details on the conference and all that kind of stuff and get back to you. And we will, again, get the results and a draft of the publication on some of the smoking cessation information and some of the other topics within the next couple of months. So we'll talk to you in about 3 months, and we'll try to get plenty of notice out, and we'll try to make it about the same time of day for the next call. So anybody with any last questions or comments?
Again, this is Sarah Lang. I didn't hear anyone speak about the telehealth issue, the topic. Will that happen on our next call?
Thanks, Sarah. Yes, that's, we have some time constraint for these calls, but we are planning to include telehealth, and that's going to be one of the topics for discussion for the next call.
Great, because our public housing authority is asking us to set up a series of clinics / telehealth programs within their housing units.
Is it a rural location?
No, it's urban.
Okay, great. All right.
That's great. So we are going to definitely include the topic and see if we can find some best practices for you from the other PHPCs or other health centers, so we can invite them and so they can share and tell us what they are doing and how they are doing it.
Great.
Great, thank you.
Thank you. Anybody else? All right, guys, we're going to sign off. Thanks for joining us, and we look forward to working with you guys over the coming year, and we'll be getting together again in 3 months. So talk to you soon.
All right, thank you, guys.
Thank you.
Take care. Bye-bye.
Bye-bye. Thanks.
Have a great afternoon. Bye.
Thank you.